All right, the next session I'll be moderating about circulation problems, all about arteries and veins, and our first speaker is Dr. Gardner. He received his BS in biology from Rhodes College in Memphis, Tennessee, and his MD from the University of South Alabama in Mobile. He did a surgical training at the Baptist Healthcare System in Birmingham. He began performing cosmetic procedures while completing his fellowship in facial and body cosmetic surgery with Southern Surgical Arts. He's moved his practice from Birmingham to Chattanooga, and since that time has devoted his practice to cosmetic surgery and advancing the modern treatment of venous disease. So Dr. Gardner.
All right. Just want to say thank you for letting me speak today. Thanks to Dr. Lassard. It's been a great conference so far. All right. So I was asked to speak about varicose veins. You know, everything you need to know about varicose veins. Basically, when we talk about varicose veins, we're talking about venous insufficiency. Specifically, and more specifically, superficial venous reflux or superficial venous insufficiency. Chronic venous disease, venous valvular insufficiency, venous reflux, incompetence, venous hypertension, stasis disease, all this means the same thing. Basically, it means high pressure in the veins, blood's going back down the vein in the wrong direction, which leads to high pressure, which leads to symptoms. The garden variety symptoms that we hear every day: aching, throbbing, restlessness, night cramps, heaviness, fatigue, itching, burning, stinging. These are the garden variety things that our patients talk to us about every day. We also start to see the physical findings. You start to see pigment skin changes. You start to see lipodermatosclerosis, and eventually you can get a venous ulcer, which is kind of the coup de grace of venous disease. We talk about the spectrum of venous disease, and basically you have spider veins, varicose veins. We talked about the other two, and then another picture on the far top right is thrombophlebitis. Statistically, and I'm not going to berate or beat up all the statistics, but basically it's a very common disorder. It's under or undiagnosed in most situations. The last time I looked, I think the SVS said somewhere between 25 and 35% of Americans suffer from some sort of venous disease and its sequelae. These patients are in your practice whether or not you know it. They're there. And I liked what I heard earlier when they were one of the doctors was talking about making the patients take off their shoes, because I can't tell you how many times I've seen a venous ulcer patient, and I talked to them, it's like, what does your primary care doctor think about this? They say, oh, they don't see my legs. You know, they're embarrassed, and so they said they don't even show them to them. If you look at the drawing, basically there's two sets of veins in your leg, deep and superficial. Deep veins carry 90% of the blood back to the heart. They do most of the work because the deep system drains the working tissue, which is essentially the muscle. The superficial system drains veins tend to drain the tissues around them, so the superficial system drains the skin and the fat because that's where those veins live, just under the skin and the subcutaneous fat. When you talk about reflux disease, it's basically you have dilation of the superficial veins. The valve leaflets basically are supposed to coapt. Well, what happens when the pipe or the vein gets bigger? The valve leaflets don't touch anymore, and eventually you start to get reversal of flow, and gravity always wins, right? So that's what leads to the symptoms: reversal of flow, high pressure, symptoms. And again, this just depicts a normal vein versus a dilated vein, which we call leaky valves, and you get reversal of flow and high pressure. Again, chronic symptoms: pain, aching, throbbing, cramping. Night cramps are one of the most common things that I talk to people about, and it's interesting because they're all put on electrolytes, they're told their potassium's out of whack, when a lot of times this is actually just an underlying sign that they have or may have venous insufficiency. But night cramps, restlessness, we start to see varicose veins, telangiectasias and reticular veins, numbness, heaviness, itching, and then spontaneous bleeding. So this is the most important slide that I can show you today. Basically, this is normal physiology. So if I were to put a pressure catheter in your ankle, in the veins in your ankle, and you can see the path that if you're lying down, it's going to be what a regular CVP would be around 5. When you start to dangle your feet and then stand, your venous pressure is going to go up to about 90. When you walk, you're engaging your pumps. There's 3 pumps: the calf pump, the thigh pump, and the foot pump. Basically, just by standing, you're engaging the foot pump. The thigh pump is less active, but the calf pump does most of the work. It takes about 7 steps to engage your calf pump. And by doing that, you're basically pumping the blood against gravity back to the heart. And you can see in the pressure curve that when you start to ambulate, you have a precipitous drop in your venous pressure at the ankle. And when you stop walking, the pressure goes back up. That's why exercise is so important. This is the curve that shows somebody that has venous disease or reflux disease. Again, reversal of flow, high pressure in the veins leading to symptoms and then physical findings. When these patients, if you put the same catheter in their ankle, when they stand, their pressure goes up above 100, and when they start to ambulate and they engage their calf pump, basically their pressure never goes down, or if it does, it's not very much. So this is why these patients have symptoms, because they have high pressure in their veins all day long. The interesting thing about it is that they get used to the new pressure. They get used to the symptoms, and so a lot of times when I talk to patients, specifically patients that have mild symptoms, and you really kind of have to ferret that out with them sometimes, what they'll tell you is after you treat one leg, if they have incompetence in both legs, they'll usually start complaining about the non-treated leg because they've gotten so used to that as a normal that once you correct it, now they would know what a normal leg feels like, so the comparison is kind of interesting. But anyway, this is the most important slide, like I said, I can show you today, and this is why it's called ambulatory venous hypertension. We all know what the calf muscle pump is. I'm not going to waste time on that, but basically this is what helps us fight gravity. With intact valves, it's a very efficient pump. Where do we get patients? Well, obviously Dr. Google, social media. Patients refer friends and family, and then primary care referrals. We do an interview, we do our H&P, and then we do a venous ultrasound. When we're evaluating patients, obviously we want to talk about their symptoms, but we also want to look further and say, have they had a previous DVT? Have they had previous SVT? Do they have peripheral arterial disease? In all of our ultrasounds, even though it's a venous study, we look at the arteries. We always look at the posterior tibial artery at least, and if we can't find that or if it's not there, then we'll look for the others. But we always document whether they have triphasic, biphasic, or monophasic pulses. If they don't have triphasic pulses, then we go ahead and do an ABI, and then if they look like they have PAD, then I send a text to Dr. Larsar and say, hey, I've got one for you. We also want to know, have they had prior treatment? How long ago? Was it effective? And basically kind of see what's happened, because a lot of these patients, unfortunately, have recurrent disease. The number one reason people have problems with their veins is genetic. Number 2 is what I tell my patients. Number 2 is hormones and having babies, which is why we see slightly more females than males, although we still treat a lot of men. And number 3 is aging. So you can't outrun those, and a lot of times you're going to be dealing with patients that have all 3 of those risk factors. Ultrasound's come a long way. When I started 20 years ago, ultrasound machines were, basically the machine was half the ultrasound room. They've really come a long way. Laptops, and we even have a little handheld that you actually plug into your phone or an iPad. It's amazing the clarity and the picture that you actually get on those smaller machines, but it's come a long way. We do studies. We basically do them in supine and standing position. We're looking for basically reflux. Again, we talked about basically veins or pipes, simple plumbing. Inside the pipe, we have check valves that open and close to allow the blood to go up, and then when gravity pulls down, the valve closes. Well, you get half a second or 500 milliseconds to allow that valve to close. Anything longer than that is considered pathologic, meaning that the valve has gone like this and is now letting blood go in the wrong direction. So that's what we're looking for. It's a very sensitive test for identifying reflux at the saphenofemoral and saphenopopliteal junctions. Those are the 2 main areas that we are looking. So when people say, well, what do we need to order? Well, you need to order an ultrasound and then an ultrasound and then an ultrasound. And what I mean by that is that's our workhorse. When you start to order these studies, you want to say, well, where am I going to get the study? Well, if you order it from the hospital or an outpatient center, a lot of times this is the kind of study that you're going to get. This is one that a patient brought in. She'd gone somewhere else. I think anyway, it was a hospital here in town. And so she went in telling them that she had a history of venous insufficiency, and you can read the top, and that she has leg pain and swelling. And then you get this long 3 or 4 lines about findings, and then the impression, no evidence of DVT or other abnormality is noted in the right and left lower extremity. And so she's kind of thinking that we're double dipping, trying to order another ultrasound. I said, well, we're really not, we see you don't have a DVT, but we really want to map your veins and we want to see what's going on. Unfortunately, this is the kind of study usually you get at the hospital. And basically, they're trying to make sure that you don't have a DVT that could be problematic for you. So always, in my opinion, get a study if you really think they have venous insufficiency at a place that does that on a daily basis. Non-surgical treatment, leg elevation, exercise, compression hose, and weight loss. Those are kind of the things that we preach. I wear a compression hose, knee highs every day. You know, if it were up to me, it'd be like fluoride in the water. We all fight gravity. I would make everybody do it every day, because when we talk to patients and and I don't have reflux, but my legs feel better at the end of the day. I have more energy. They're less achy, less tired, less fatigued. And just like you guys, I'm sitting and standing and seeing patients all day long. The way the hose work, they're tightest at the ankle, less tight as they come up the leg. I'm going to spend just a minute on this. I see patients all day long, and it's interesting how much money they'll spend on hose from Amazon and Walmart and Walgreens. And then when they come in and we measure and fit them for hose, they're usually not in the correct hose. They're in something that's way too long. They fold them down, which doubles the compression at their knee, which actually makes things worse instead of better. So my recommendation is find somebody that measures and fits their hose. It's not one of those, I think I'm a medium, I think I'm a large. You really want to know what's their ankle measurement, what's their calf measurement, and you want to know the length from the floor to the knee if you're going to put them in a good knee-high hose. Typically, we recommend class 1. The other thing I'll say about that is always check pulses. The down and dirty way, at least from my perspective, is if they have palpable pulses, then they should be okay putting them in a class 1 20 to 30 millimeter medical grade compression hose. If you're concerned, check their ABIs. If you don't do ABIs, then send them to some place that does ABIs just to make sure, because the worst thing you could do is put somebody in ill-fitting hose and then cause them to have issues if they have an ABI of 0.6. All right, they're not your grandma's hose anymore. The other problem that we see is nobody wants to wear hose, but I have patients that are diehard Tennessee fans that order the, the funniest orange thigh-high. Seeing a guy come in thigh-high orange compression hose is hilarious. But they're not your grandma's hose anymore. They're stylish. We have some people that will come in and they'll buy them. Professionals that wear skirts all day and they'll wear the thigh-highs. They're really good quality too. Surgical treatment. This is from Linton's Vascular Text. I bought it online about 15 years ago for 10 bucks. It's actually a really interesting text when you kind of look at what was standard in the 70s. This is stripping. We don't particularly do stripping anymore. I know that it probably is still done in certain situations, but I haven't done any stripping since residency. It required big incisions. We didn't use ultrasound. You basically cut down, found where the vein was supposed to be, and then you did your procedure from there. Now we use minimally invasive procedures, intravenous ablation, thermal ablation procedures, either laser or radiofrequency. There are commercial foam preparations, and there's also glue. I'm going to talk about just the thermal ablations today. Basically, we access at the knee with a needle stick. Once we gain access, we run either the laser fiber or the radiofrequency catheter up into the vein. We go from the knee to the groin. We stay typically about 2 to 3 centimeters away from the groin because we don't want to injure the deep system or cause any problems. We then infiltrate the leg with a tumescent anesthesia solution. Tumescent anesthesia was introduced by Jeffrey Klein, who's a dermatologist, and he's the kind of the father of tumescent liposuction, but this is where it came from. But it's a dilute solution, so we can use quite a bit of it, and the toxicity is not there. You can go up to 50 milligrams per kilogram and still not reach toxicity for lidocaine. So anyway, once that area is numb, it causes the vein to actually collapse down around the catheter, and then we turn the heat source on, it gets hot, and then we slowly back it out of the leg. It's very effective. a very low recurrence rate. This is just a procedure where we've marked out a couple of veins that we're going to treat. We access them using ultrasound guidance. Catheters placed. You can see the aiming beam on the laser as it is easily visible through the skin. This is basically just a little vein that I took out for other reasons. It's got a big venous aneurysm, and you can see the charred areas where it's been burned by the laser. I actually burned this ex vivo. I didn't burn it inside the patient because it was stuck to the skin, and you'll burn the skin if you do that. So I'm going to show just a little quick video. Will you hit play, please? So this is a radiofrequency catheter, and basically, again, it just shows that once you start the heat, the vein will literally just shrivel up. And it's a very effective technique. Again, most people are back in the swing of things within a day or so. Most people, if they don't have a strenuous job, can go to work the next day. And again, recurrence rate's very low. We do adjunctive procedures such as phlebectomy and sclerotherapy. This is somebody that came in, had veins removed 20 years ago. So these are the incisions that a lot of people used to make when removing, bulging varicose veins. We don't do that anymore. Same thing. So we basically make a puncture, 1 or 2 millimeters. We hook the vein. We then remove the vein, and we can remove long segments of the vein. So we'll mark them standing up. We also have a vein light and vein viewer that we can see when they're supine. But anyway, you can remove long segments of vein through little 1 or 2 millimeter punctures. This is another picture showing big incisions from basically 20 years ago. This patient had recurrent disease. The little poke holes that you see are from me, and those will heal up and be very hard to see. We do a lot of sclerotherapy. We do this for both cosmetic reasons as well as for medical therapy. Interestingly, when people come in for solely cosmetic reasons, a lot of times only about 20% of those have purely cosmetic issues. The problem is they just don't know it. And we do screenings on a lot of those patients to identify other disease and then just talk to them about what may be going on with their legs. You can see the sclerosant. Basically, instead of using heat or thermal energy, we use a chemical to sclerose the veins down. Just like with the thermal ablation techniques, once the veins are damaged, your body is very efficient at getting rid of these veins. Typically, if we do a thermal ablation, 6 months from the procedure, you'll see an obliterated fibrous cord where the vein used to be. Usually at a year, you can't even find the vein anymore. Your body is so efficient at getting rid of damaged tissue. We use ultrasound-guided techniques. We use visual-guided techniques. This depicts it's just showing a patient before and after treatment. Again, when you see that patient, you look at the big bulging veins and you think, well, that's the primary problem. Really, those are veins that come off of the saphenous vein. So this gentleman had saphenous, typical great saphenous reflux in both legs. We ablated the veins, and then we made multiple little punctures doing the phlebectomy technique, and we also do sclerotherapy. So when we do these procedures, I call them a blue plate special. We do laser, or RF, we may do sclerotherapy, and we may do phlebectomy all at the same time. They do tend to get a nice cosmetic result, but that's not the goal. The goal is to improve symptoms, get rid of the aching, the throbbing, the heaviness, and the night cramps, and all the things that go along with it. This patient has lipodermatosclerosis, and in my opinion, when you start to see skin changes, to me, that is what I call a pre-ulcerous condition, just kind of like some of the podiatry physicians were just saying. This patient in the before picture has a heavy leg, it's tired, it's fatigued. I heard Tina mention the gaiter area earlier. The pigment changes start just above the ankle in the gaiter area. That's what this gentleman has. The lipodermatosclerotic or sclerotic changes, and basically you get inflammation of the fat, and it's a sclerotic change, and we call it woody induration. You can see it regress, and so what you can appreciate from the photos is when you grab the leg on the right or on the left, it's basically firm and hard, and it has that woody induration feel. 6 to 9 months later, a lot of times that inflammation and those inflammatory changes have reversed, and it actually feels nice and normal again. Ulcers will heal. This is a classic great saphenous ulcer. This lady, interestingly, and we see a lot of these, so when you look at a patient's legs, She doesn't have any visible varicosities, but this is a classic great saphenous ulcer. She's had this ulcer for 2 or 3 years. She was sent to the dermatologist because nobody knew what it was and they thought it was a skin lesion. We put the probe on. She's got a 10 millimeter saphenous vein. We ablate the vein, and within 2 weeks, the ulcer that's been there for 2 or 3 years is healed. So they tend to heal up very nicely, but the caveat of that is if you look at her legs, you would never look at those legs and say, well, that patient has clear venous insufficiency. That's why the symptoms are so important. The aching, the throbbing, the heaviness. When you can't find anything, sometimes they need to be sent for an ultrasound just to make sure that their symptoms are not coming from underlying venous disease. This is another one. This patient came from Alabama, and her cardiologist had ablated her saphenous veins, but her ulcers wouldn't heal. She's got ulcers on the lateral aspect, a small saphenous ulcer on the left leg, and a great saphenous ulcer on the right leg. These actually ended up being perforator ulcers, and so we treated both of these, and within about 4 to 6 weeks, you can see her legs are much improved. Cosmetically, yes, but again, that's not the goal. This is an ulcer that I treated in Birmingham, and interestingly, the same thing. If you look at her leg, you don't see anything on her leg other than she has some spider veins along her arch, and then she had this breakdown. And so we ablated her. I literally stuck her about 1 inch above the ulcer. We ablated from the groin all the way down, and this is what it looks like now. I did go ahead and cheat a little bit, and once it granulated in better and was flat, I went ahead and skin grafted it just to heal up the process. But this is a classic great saphenous ulcer, even though it looks kind of odd. So this is why vein disease is important. So the before picture, I saw this gentleman, it's been 5 or 6 years ago, and when I was talking to him about treatment, one of the things I mentioned is that a DVT is one of the possibilities as far as risk with any procedure. Well, he got freaked out by that, so he left and he never came back. Well, I should say that. He came back about 1 year later. So this is the advancement. So no hose, no compression, no change in lifestyle, and nothing. And so this is him about 1 year later. And so this is completely preventable. So that's why when I see skin changes, to me it ups the ante, and those patients really need to either be in good conservative therapy and followed closely to make sure they're not progressing, or they need to go ahead and have treatment. Here's another one. This is a patient that I saw. This was more of a social situation, and this guy, really nice guy, but he basically didn't show back up for 9 months. And I said, well, what happened? Why didn't you come back? And he said, well, I just couldn't find a ride. And so it was interesting, but his daughter was a nurse, and once she saw his legs, she brought him back, and we were able to treat him. But he developed ulcers on the back of both of his legs within a pretty short period of time. So these things can advance. They don't always do this, and you're never going to know which ones are going to advance, but it does happen. This is a patient. She has basically mixed disease, and when I say mixed, I don't mean arterial and venous, I mean venous and lymphatic. And there's a constellation called phlebolymphodema, and so she's a classic phlebolymphodema. And basically, so when she came in, you can see she's walking with a cane. This is her after treatment. So the way we treated her is we used lymphedema therapy first to decompress her legs. Once we had her in a maintenance phase and in daily compression, then we went ahead and treated her legs. And so I asked her afterwards, I said, okay, so here's the question I have for you. How much improvement do you think you have after treatment of your veins? So a lot of people would say, well, just treat the lymphedema and leave it at that. Well, she had venous insufficiency on top of that. So my question was, how much better are you? And she said 20 to 30% better after going ahead and treating her veins on top of the lymphedema therapy. So you have to kind of make sure that they don't have this. Now, a lot of times it is just lymphedema, and that's all they need is lymphedema therapy, but you really want to figure out what you're dealing with. This is her every day. If she doesn't wear these hose, she will balloon back up because she has lymphedema, and you can't fix that. This is another patient. He's also a phlebolymphodema patient. This guy was very depressed when I initially saw him. His wife brought him in. He really didn't have much hope. The wound that you see is a lawnmower accident, so that has nothing to do with his care, but basically we did lymphedema therapy and then we treated his veins. Spontaneous bleeding always happens in the shower. They always describe it as a hog killing. And I always ask him for pictures. And finally, this guy whips out his phone and he gave me some pictures. So this is his bathroom after spontaneous bleeding. And I've got even better if you'll hit play. So this lady, is it going? We hit play. So anyway, this is another interesting one. Same thing. I always ask, we probably see one or two of these a month. And so this is her, and she's in her kitchen. You can see her linoleum. And what you'll notice is that it's usually not a big varicose vein, but when you start to see those really dark veins, what that means is they're eroding through the skin, and there's only literally a couple of cell layers. And what happens is they get in the shower and they start scrubbing with a washcloth, and they abrade it or they shave across it. But you can see a little stream, and so she'll put her finger on it, and then she'll move it away. And this is her. That's how much pressure is generated when in the lower leg when you have venous hypertension. So there it goes. I don't know if you can see the stream, but she'll start moving her leg and you can see the blood. But I thought it was fairly interesting. But this is something that happens. A lot of these patients end up in the ER unnecessarily. It's fairly easy to treat. All right, so when I said these patients are in your practice, this is us at Disney. My kids are a lot older now, but you can see this guy. He's got significant venous disease. You see this guy? It literally got to the point where my kids are like, hey, Dad, there's another one. And they would go stand next to him so I could get a picture. Now, that's my wife. She was not enthused and got kind of irritated. But these patients... Now, I will give this guy an A+ for wearing hose, but he gets a D for rolling them down. This is the exact thing that I'm talking about. If you roll those hose down, you double the compression, which means now he's got this band about this thick that's tighter than it is at the ankle, which is actually going to make his symptoms worse. There's another one. There's another one. There's another one. Now, this guy is actually going to get an ulcer. And he has significant breakdown, huge veins, and about to get an ulcer, but that's my daughter. And there's another honorable mention. And to be fair, those are my legs. Okay.
All right, that was very nice. Thank you, Dr. Garner. I'm the next speaker, so we're going to talk about some veno-occlusive disease, advanced therapies. It's kind of a hodgepodge of things. There'll be some maybe an interesting case or two. So we just finished talking about venous insufficiency. So, when the veins get stretched out. Now we're going to talk about veno-occlusive syndromes and different types of advanced therapies that we have these days. Back in the olden days, it was just put you on blood thinners. So, when, my mom was having, babies back in the, 70s and 80s, you get a DVT and you're pregnant, you just get put on blood thinners. And then what ends up happening is something like this, where you had a May Thurner, you occluded your iliac vein, got a DVT, and now you have post-thrombotic syndrome, big swollen leg for 30 years, have to wear compression, you get an ulcer. So these days we have advanced therapies that can treat that and hopefully prevent things like this. So this is, end stage, what we don't want. DVTs are very common. You get this post-thrombotic syndrome if you don't treat the acute clot when they come in. So acute iliofemoral DVT. There's lots of things we can do. Put them on a heparin. Back in the old days, they did have surgical open therapy. So when you came in with phlegmasia and you were going to lose your leg, which is very, very rare, we could do an open thrombectomy, make an incision in the groin, hold up your leg, wrap it with an S-mark, and squish all this clot out. But that doesn't necessarily treat a potential compression in the iliac vein, which a lot of these patients that have iliofemoral DVTs come in with. They have a compression of the iliac vein, like a May Thurner. They get this big iliofemoral DVT, and then what do? Well, we also have lysis, so we can put a catheter in there, drip TP overnight, but a lot of patients have contraindications to thrombolysis. So there's a fairly new on the market, different catheters where we can go in there and perform percutaneous thrombectomy in one setting, minimizing blood loss, minimizing the amount of TPA or lysis we have to do, reduces the post-thrombotic syndrome that they may have if you don't treat it, and improves their quality of life. So here are just some pictures of a kind of iliofemoral DVTs. These are two I've done this year. I think they were both COVID related. They both had a May Thurner and they thrombosed their whole leg when they got COVID. This is before and after. You can, both of these, they're kind of hard to see, but say your top, the right-sided picture, the top is the femoral segment, and then the bottom picture is actually like the common femoral external iliac. We cleaned it out without using lysis, kind of percutaneous thrombectomy, and then ended up stenting on that bottom right kind of blue picture. You can see the tip of a stent that treated the compression at the same time. Put them on anticoagulation. You're done in one procedure, and their leg miraculously gets a lot better. And then the next picture, the same thing. We're able to kind of debulk the clot and treat their iliac vein compression at the same time. So very cool things. Now, what do we do about the patients that had their clot 20 years ago and we didn't have these cool methods to treat their acute clot? Well, most of these patients, they got a filter, they got put on anticoagulation, and they come in 20 years later with big swollen legs, still thrombosed, light compression, chronically occluded, and they have this venous outflow obstruction. What do we do? Now, Dr. Lassar is going to get into stuff like this in the next talk, but there are things we can go in there, we can put stents in, we can take their filters out, reconstruct their IVC with stents. 20 years ago, we were using arterial stents in the venous system. Now we have dedicated venous stents in the venous system that work really well, that we can put in, and patients are very, very happy. So another picture. The right side iliac vein looks great, but that left side where that May Thurner is, chronic compression, causing outflow obstruction, put a stent. This is actually kind of an older picture because that's a wall stent. There were some of the first venous stents we put in, but those are only indicated for kind of tracheobronchial stents. Now we have dedicated venous stents. So, all right, so that's kind of legs. Like I said, we're going to kind of jump on over. So you can get, obviously, DVTs in the upper extremities, and one common thing that we see is venous thoracic outlet effort thrombosis, or Paget-Schroeder syndrome, which is usually in younger patients because this is kind of an anatomic compression of the subclavian vein between the subclavius muscle, the anterior scalene, and that pinch point between the clavicle and the first rib. You can also have cervical ribs bilaterally that cause this. Usually you have repetitive motion, they get a DVT, huge swollen arm, painful. What do? You have to decrease this, you have to get rid of this compression. You can treat the clot acutely if they have a lot of symptoms. You can go in there and perform thrombectomy, you can thrombolysis, but it's going to come back and they're going to continue to have symptoms unless you treat this. And treatment, fortunately for us as surgeons, it's kind of a combination between endo and open. You have to remove the first rib, you have to remove the cervical rib, take off that anterior scalene and decompress that subclavian vein in an open manner, and then if you need to treat the vein endovascularly with a balloon afterwards, we can do that as well. So this is a patient I actually did, I guess about a year ago. Very, very healthy female, repetitive motion, came in with a big swollen arm, didn't really know what it was. She has acute axillosubclavian DVT. You can see kind of all those collaterals trying to drain her arm, but the big main axillary vein subclavian are thrombosed. You can kind of see, dense black contrast, and then it just ends where the DVT is. Able to sneak a wire through. Actually use the percutaneous thrombectomy device to kind of debulk some of that clot, to kind of get some outflow and improvement in her symptoms. And then you can see that tip of that catheter is right at the first rib subclavian junction. You can see that pinch point or that narrowing right before it dumps into the superior vena cava. So we knew what she had. There's another kind of picture with clot in that pinch point. So ended up leaving a lysis catheter overnight just due to the clot burden. Came back the next day. This is how much it's cleared with lysine. So it's nice and clear. Her symptoms had improved, but what do we need to do? We need to take out her first rib as well. So that's another little picture after balloon angioplasty, just to ensure there's no was no real significant residual stenosis. And then that's kind of after. Put on blood thinners, but these patients, since there was a compression, they don't have to stay on blood thinners once you get their first rib out, and after their clot's gone and you've treated their vein afterwards, then they do pretty well. So now we're gonna switch gears and kind of do a zebra case. As you know, these are super rare cases, and I had actually never heard of this case, something like this, until I got to fellowship. And it was pretty ironic because I was studying for, I think, my oral boards and vascular. And one of my attendings sat me down before it, and he was just like pimping me about this case he had 2 years before, and I absolutely had never heard of something like this. And I'm glad he did, because no joke, 2 weeks later, a patient presented to the emergency room with these exact same symptoms, and nobody knew what it was. And I was like, me, I know exactly what this is. This is what we need to do. And they were like, no, I've never heard of that. How did that happen? And I was like, listen, we got to do this. The patient is dying. This is what we need to do. So this is the patient that actually came to the ER. So she was a 65-year-old smoker. She presented to an ER. She was hypotensive. She had acute onset of back pain, kind of like left lower quadrant pain. She was short of breath. She had a cold blue leg. She was motor sensory kind of decreased in that leg. She had never had any real medical problems besides being a smoker. And this is what her leg looked like. So anybody know what that picture, it's phlegmasia. So phlegmasia, so we think, oh, she's at acute DVT. However, she's hypotensive. Her hematocrit's low. Her hemoglobin's 8. Her pulses are normal, but she has also back pain and left lower quadrant pain. Heart rate, she's tachycardic. They kept calling us, she's hypotensive. Her hematocrit's dropping, what do we do? So they scanned her at the outside hospital. I don't think this is going to play, but so she had this huge retroperitoneal hematoma on the left side. Maybe it'll play, maybe it won't play. So arteries were normal, no clot there, but huge retroperitoneal hematoma and acute clot in her lower leg on ultrasound. So what do you do? Put her on heparin and then she keeps bleeding. And what do we think? What do we think this is? Anybody ever seen it? Say that again? May Thurner, but why is she bleeding from it? Have you ever seen somebody bleed from May Thurner? Does she have two things going on? She's bleeding from somewhere. Now she's, super hypotensive, and they're giving her blood, and we can't put her on blood thinners because we're having to give her blood. So what do we do? So we took her to the operating room, because I knew what this was because my attending who had a patient just like this, he took her and X-lapped her because he's like, I don't know what's going on. She got an expanding hematoma in her pelvis. She's basically bleeding to death, but she also has acute occlusion of her vein. So he took her to this is not the patient he took an operating room, found a huge hole in her iliac vein from a ruptured May Thurner. Who had ever heard of that? Not me. So we took this patient to the operating room, and I told him, I said, we need to do a venogram, because you couldn't see this on CT scans. It was just basically this huge hematoma. You didn't know where she was bleeding from. So we actually came from the other side to put a filter in first. So you can see a filter we actually put in from the other side because she did have some PE. We wanted to prevent anything else from going up there, and we shot this venogram. This may play, actually. Yeah, there we go. So a huge hole in her common iliac vein on the left. Active extravasation. We don't have stents made for this, really. So we ended up putting a EVAR limb to cover this extravasation and save her from bleeding. This picture of an ultrasound is actually her common femoral vein. You can see basically her whole leg was clotted on the vein side, and she was ruptured and actively bleeding. So we covered it. We did percutaneous thrombectomy. We actually accessed the POP, and so once we covered it and stabilized the rupture, did percutaneous thrombectomy of her entire leg, got the clot out. And that's a nice video. That's acute thrombus in her common femoral vein. As you can see, that's her left side. And you can see that clot kind of bulging out into her inferior vena cava. So after we put the limb, we actually extended up with a wall stent to treat that compression, because the reason she ruptured, and she had a spontaneous event of increased venous pressure for some reason, and ruptured it. So that was before mechanical thrombectomy, and this is after mechanical thrombectomy. So cleaned out her leg, did some more balloon angioplasty, and that's it. So the rupture's covered. She still had some residual clot, but you know, we were pretty happy that we had, you know, she didn't die on the table. So this was actually the next morning. We wrapped her leg. I took her wrap off the next morning. Her leg looked pretty much normal. We repeated ultrasounds before she went home. Really had no DVT left. She went home after about 7 days on aspirin, Lovenox, and then Coumadin. She did have a lupus anticoagulant workup, and then on follow-up, 6-month follow-up, this is kind of her CT scan. You can see that filter still there. We're going to take out, and we took out, and then she had a wall stent in that other limb, but she did really well. So anyway, never heard of that, but you can have a spontaneous rupture of a May Thurner, to the point where not a lot of people see it, so they don't know what to do. You have a bleeding and an obstruction, and you put them on blood thinners, and they have a very high mortality rate. Another one. So the first case I was talking about that my attending told me about, when he X-slapped the patient, he was just able to fix the hole, oversew the hole, but he did not treat the May Thurner, did not treat the compression. So that patient survived from their bleed, but then they still had obstructive symptoms a year later because their May Thurner wasn't fixed, so they had to go back in endovascularly and treat it with a stent. So just something to keep in mind if you ever see anybody like that. So takeaways: thrombus management, both in the acute and chronic phases, we can treat thrombolysis, take out the clot, thrombectomy with stents, but you have to treat the compression that's causing the symptoms if it's there in the iliac symptoms. And that's about it. All right. Dr. Losar is next. You're going to talk about what, the kitchen sink? Okay.
Liz, that was an amazing case. I was struggling to kind of figure out what was going on there, but I'm glad you knew, so I'm glad I have you as my partner. We're going to talk a little bit about the impossible venous ulcer, and then, you know, how do you throw the kitchen sink at these things? Because some of these problems are incredibly chronic and incredibly complex. But when we look at the prevalence of chronic disease states in the United States, we see that I've gotten older and I think I need my glasses. Yes, there we go. I can see again. So we can see that you know, if you add Alzheimer's and stroke and cancer and heart disease, PAD and diabetes, if you add all of that up, it doesn't even equal less than half of what chronic venous disease is. And so chronic venous disease is incredibly prevalent, and it is part of things that we deal with all the time. So you probably thought I was going to put some kind of ugly picture up here, but here we have, you know, this leg here, and does this patient have venous disease? It kind of looks like she has a bruise, you know, on her thigh, probably from back there, but from here, now that I have my glasses back on, I can see the telangiectasia that she has. And so she does have venous disease. She has chronic venous insufficiency. Now we call this a C1. You know, the C classification is pretty complex. I kind of keep it simple. It's going to be C1 through C6, and C1 is telangiectasia. C2A is asymptomatic. I'm blanking on, help me out here. Thank you, varicose veins. And C2S is maybe someone that is symptomatic. So when you start to get into the upper stages, C3, you're going to start to have edema. And like Dr. Gardner was saying, when you see C4 disease in the staining of the skin, those are patients that are, you know, potentially pre-ulcer. And so who do we operate on? Well, we're going to operate on anybody that's a C2 symptomatic, as long as they're agreeable with it. C3s, C4s we're going to fix, and then obviously C6s. So a C6 is where you have the venous ulcer, and a C5 is where the venous ulcer has been healed. So that's the classification system that we have. Now these ulcers are incredibly resistant to healing. This is chronic damage, chronic skin changes. This is years of venous hypertension, and the annual incidence is for these venous ulcers about 1 to 2 million. Now, I've got a couple slides in here that I borrowed from Mary Yost from the SAGE group because the data is so current and prevalent, or current and accurate. And so even though there's an incidence of 1 to 2 million a year, there's also an increasing incidence with age. And so what does this mean? You know, most of the time, venous ulcers have really poor healing rates. So at 6 months, only 35 to 50%, or 35 to 50% are unhealed. And at 2 years, you can still have about 20% that are unhealed. So these are incredibly difficult things to deal with for your patients. Now, because of the poor healing rates, there's an increased cost for these patients, and then we've estimated the monthly cost to be about $2,900 a month. That's in supplies and medical things, it's travel back and forth to doctors, things like that. But there's also some costs that are maybe a little hidden that we don't think about. The ulcer management expense, we think that's $2,900, so it's about 14% of income. Unemployment can play a role in their life because of these problems, or they can be forced to retire early because of the chronic problem. So they also have a reduced quality of life. You know, ulcer treatment is burdensome, it's time-consuming. They have chronic pain, sleepless nights. They have reduced mobility, problems with daily living care. Self-care is a problem, inability to work, inability to exercise. The odor, the swelling, and the discharge that comes from these wounds are horrendous. And then a negative emotional impact of, you know, fear of talking about it, you know, depression, and then social isolation because of this. So how do you manage this? I mean, when this comes into your office, what do you do? How do you think about this? Well, I think the first thing you have to recognize is, you know, this is not just a spider bite. If you look at that skin, look at her ankle, you see that darkening of the skin near the ankle. So this is a chronic venous disease. So the answer is probably not a spider bite. This is chronic venous insufficiency, and we now have an ulcer that we have to deal with. So when you have a wound like this, I think there's kind of 3 things I need you to think about. First is there a circulation problem, is there an infection problem, or is there a biomechanical problem? And so as far as circulation, I think a good pulse exam, you want to rule out arterial insufficiency as a source for that circulation disturbance. But you're also, importantly, to fix this patient, you have to wrap their leg. You have to put pressure on that leg. So you need to make sure that they have adequate pulses, like Dr. Garner was saying, and then if you can get an ABI test, I think that's a reasonable thing to do. Now, the other part of circulation, for circulation to happen to be normal, it has to flow in artery, it has to flow out vein. And so the 2 things that are going to be a problem are venous reflux, like Dr. Garner explained very, very eloquently, and then also venous obstruction. So that's May-Thurner syndrome. That's where the iliac artery compresses the iliac vein, and you don't have outflow of blood in the venous system well. It could be postphlebitic. They had an old blood clot that sits in there, but there can be venous obstruction as well. And so when you have that pathophysiology, then you have high venous pressure as a biomechanical issue. And so if you treat the leg with a good wrap and you also deal with infection, then you can start to get that under control. So that's the mainstay of what you have to think about. Now, these venous insufficiency symptoms, they predominantly come with a swelling that's going to be a problem, eczema, hyperpigmentation, dermatoleucosclerosis, ulceration, and pain and bleeding. The pathophysiology is reflux, it is obstruction, and it could be both. And so we're very good at treating reflux because there's many vein centers in the country that treat reflux and the saphenous all the time, but we've poorly understood how to deal with obstruction. And part of it was we didn't really have the technology to actually fix the obstruction. So why are we going to looking for it if we can't really fix it? It's just, you know, this is your condition, this is what you're stuck with, this is how you have to live. But I think we understand now with the newer technologies that we have with the venous stenting that we can actually fix a lot of these problems. So in the diagram where the veins are functioning well is that normal control right in the middle. You can see that there's the valves and the saphenous are not working right, and then there's reflux in that area. The pressure when you stand up, again, is about 90 millimeters at the ankle, and if you don't stand or move or walk, then that pressure is stagnant, and people can have pain, pressure, heaviness they describe in their legs. So the normal flow dynamics for venous flow is superficial to deep. It should go from superficial veins to deep veins back to the heart, and that's the fairly normal. When you augment that with exercise, you start getting the calf pump into play, you can really get augmented flow coming out of the deep system, and the superficial system can maintain compliance and still move it from superficial to deep. But when you have obstruction, then you have retrograde flow. You can have more pressure on the valves. You start to lose some of those valves, and that's when you can develop a dilated vein in the thigh. And so this is kind of the understanding of when we start treating these patients, what we're thinking about is trying to define what their particular problem is. This is I would say the standard way that we treat venous patients in the country. You have a problem like this, they come in, you start a wound care, you're going to wrap them, you're going to start a medication. We had our 2 certified wound nurses here saying they're going to try something for a month, and it didn't work, so we're going to try something different, and it's basically the same, and we're going to try something different. And now we're 3 months into this, and we're still kind of dealing with this, and it really hasn't changed too much. And part of it has to do with the fact is we haven't changed the pathophysiology. We haven't solved the problem. We haven't fixed the hypertension, the venous hypertension. And so this is where a venous ultrasound reflux will come in, and you can see in the top circle that we have deep reflux, and we have also superficial reflux. Now superficial, we can do EVLT or do ablative therapy like that. Deep reflux, it's always been something we've known about, and we can't fix the valves in the deep system, but we can fix obstruction. And so currently, the first step in this issue was, let's see if we can deal with that superficial reflux and see if we can get this wound to finally heal. So we do EVLT, we reduce the superficial venous reflux, and that didn't ultimately solve the problem. So then we're looking at the deep system to see if there is obstruction. And so we can see in the middle, you see about a 70% stenosis in the top panel of within that vein. And we've confirmed that with the intravascular ultrasound. That's basically like driving through a tunnel, and you can see inside that vein what's actually happening. You can see scar tissue. You can see a compression on that vein system. And then in the right upper quadrant or right upper corner, you see the stent placed where the yellow arrows, and then we always follow that with an angioplasty, a venoplasty, to open that up. And so with continued wound care, which you still need, and you've reduced the venous hypertension, at 6 months we've had pretty good result. We did treat that with an EpiFix application, and at 6 months, 2 weeks, we pretty much have a closed venous wound, which is very complex. This is a very complex problem. And my thoughts are, I think you have to recognize that you have to go after the pathophysiology sooner. Maybe we could have cut this back to 3 months, I don't know. But again, one of the things that is important is that we start to move forward to try to fix the pathophysiology. Wound is healed, happy day, moving on. This is a chronic condition that's just that's horrible for these patients. They have thickening of the skin, they've got dermatoliposclerosis, the darkening, onychomycosis. Their wounds are very difficult to treat. This has been treated with skin grafts before and placement of skin grafts. And sometimes we can do the deep venous reconstruction, we can do the superficial reconstruction, but oftentimes I've found in these patients, when I look directly over that ulcer bed, that they still have this plexus of veins. And it's very complex, and there's almost always, we find it right where the ulcer is. And so one of the things that we've been adding to the mix to reduce that venous pressure is we can cannulate the different tributaries, we can cannulate the saphenous, and the picture on the right shows the setup for both systems that are cannulated. And then we can use a foam that we create, the polydocanol injectable foam that will ablate these veins. You can kind of see it on the right panel, the foam kind of swirling within the vein system. This vein had some chronic thrombus in it as well. But I think with treating this venous bed and wrapping this, then we can move, hopefully from a C6 to a C5 and actually heal the wound. But I think you have to pay attention to the different areas that are where the venous hypertension can be, and then we can get patients moving better. And so what I wanted to point out was that for chronic venous insufficiency, I say it's commonly misdiagnosed. What we saw this presentation right here was the tip of the iceberg. This one's easy. It's venous disease. It's a venous ulcer. Everybody can say that in this room, and it's just what it is. But it's the only tip of the iceberg. What about these patients? The patient in the upper left that they're putting the indent into the foot. Is this lymphedema? How do you know? One of the common things to say differentiate between edema, peripheral edema, and lymphedema is that you have sparing of the toes for the peripheral edema. If you look at the toes in the bottom, in the patient's on the left bottom, she has a very swollen right leg, and the toes, I would describe them as boxcars. They look like little square toes, and there's no space in between, and her left foot is perfectly normal, but that's more consistent with a lymphedema style presentation. So what about the patient sitting on the bench? Does she have heart failure? Is that her problem? Does she have lymphedema? She clearly has, at least a C4 on the left and really right, with the darkening of the skin. What do we do about swelling? It's one of the most common complaints that we get all the time of how to think about this. But can lymphedema, people who are diagnosed with lymphedema, actually be chronic venous insufficiency with veno-obstructive disease? And the answer is yes, because we find them all the time and we stent them and they get better. Can they be heart failure? Absolutely, this could be heart failure. Should you have them, seen by a cardiologist and tested and to verify that their BNP is normal or abnormal? And if it's normal and there's no signs of a valvular disease, this is not heart failure. This is swelling. So swelling is not a diagnosis; it's a condition. And so if we have just swelling and it's not heart failure, then it's something else, and it very well could be venous insufficiency. A lot of the patients that we treat with venous stenting, they've had a hysterectomy in the past, or they've had spine surgery. There's been some manipulation of that vein, and they can have obstruction. Or post-phlebitic, DVT in one leg. They thought it was just the leg, but maybe it actually was a little bit higher. Pay attention to people with unilateral symptoms, unilateral swelling, unilateral pain, and central obesity will play a role in decreasing venous outflow. It's kind of like putting the brakes on the venous system. And so that can also mimic central venous obstruction. They have central venous insufficiency, but they may not actually have obstruction. It may just be central obesity. So one of the things that we do fairly commonly is to scan. When we have a patient come in with a venous disease, we used to just scan the lower leg. Now we scan the lower leg, but we also scan from the hip to the chest. And we look at the vena cava, look at the iliac system, we measure everything. And sometimes we can correlate that narrowing in the vein system to the symptoms that they have and actually start to treat them. So just some thoughts about swelling and chronic venous insufficiency, and I thank you for your time.
So when Chris gave me this lecture about polyvascular disease, I was a little perplexed. Didn't know where to start, but I wanted to start at the basics because I think it's really, really important to drive home. And I'm old school. My father was a primary care physician, still is actually, and he always kept referring to the history and physical being the very most important thing. So when you're treating a patient who you have suspected either peripheral arterial disease or venous disease, your history is the most important thing. what's their occupation? Are they a nurse? Are they standing on their feet for long periods of time? Are they bedbound? Have they had acute swelling? Have they had chronic swelling that's worsened over the last time? Do they wear compression stockings? Does the compression stockings help? Things like that. So, do they have a family history? When you're, when you see a patient with leg issues or any vascular issues, I mean, history and physical is so incredibly important. I can't tell you how many times that Dr. Lassar, Dr. Hartman, and I have seen patients present to our office with a giant abdominal aortic aneurysm, and you look at the patient laying down, and it's like a gremlin coming out of their stomach, and you're like, did you ever notice that? Did anybody ever notice that? And the answer is typically no, but it's amazing how quickly a physical exam would have picked that up. So, we do physical exams when we're looking at arterial systems, both supine and standing. And oftentimes, as Dr. Gardner alluded to earlier, that can make the veins become more pronounced when they're standing. The ulcer, we always document the size, location, what kind of ulcer it is, how superficial it is, how deep it may be, if there's surrounding edema, if there's edema in the area, chronic skin changes, presence or absence of distal pulses. We categorize so many things as either a venous ulcer and arterial ulcer, but so oftentimes, especially with the elderly, there's a mixed morphologic case. And we remind this to, sometimes we get blinders, horse blinders, and we are so focused on the fact that it could be venous, but a wound may not heal because it's arterial. So it's important to check both. You can have this in exactly the same patient. So signs and symptoms of venous insufficiency, we've already beat that to death. But if conservative measures aren't working, you need to be aggressive and send a patient to a vascular surgeon or to a vascular center for non-invasive studies to further investigate this. When to move faster, this goes back to your history. If the patient had new onset symptoms within the last 24 to 72 hours, something like that, within the last week, you obviously want to rule out what will kill the patient first and fastest. So do you want to do an ultrasound, arterial ultrasound, stat arterial ultrasound to rule out some sort of arterial ischemia, acute arterial ischemia? Or do you want to do some sort of acute ultrasound to rule out a DVT? A DVT ultrasound takes 10 minutes, 15 minutes in the right setting. A venous reflex ultrasound, like Dr. Gardner was alluding to earlier, takes a whole lot longer. But we can do a DVT ultrasound pretty rapidly if you're worried about an acute venous thrombosis. In these instances, it's really important to get those referred as fast as possible. So pick up the phone, send them to the emergency room if you have to, but we can get them into an ultrasound lab typically within the same day if there's an acute issue. And then once they're seen, the history and physical guide the timing of the revascularization, be it acute, in an arterial thrombosis, obviously you do it that day or the next day or something like that. One other thing, going back to history and physical, is get their systemic history as well. Do they have atrial fibrillation? Do they have a history of clotting disorders? Things like that. They may guide your therapy and guide your investigation as well. So coming from you guys in the front line, obviously medically optimizing the patient is tremendous. So if, as you're triaging them and things like that, make sure they're on the appropriate medications. Statin therapy for anybody with PAD, some sort of antiplatelet therapy. Don't listen to what you hear about in the New York Times as far as antiplatelets. Everybody should be on them as far as we're concerned. And, medical adjuncts, especially for somebody who has chronic limb ischemia, sometimes smoking cessation, things like cilostazol can help their symptoms tremendously. And then what happens once they get to us? That's really important. We'll see them, and oftentimes if they have a wound or something like that, we'll perform an ankle brachial index, look at bilateral lower extremity arterial duplex. We always say ABI, but an arterial duplex gives us kind of a roadmap of what we're looking at, specific locations as to where the degrees of stenosis are. We'll do pulse volume recordings, not as much as we used to, but sometimes they're still, PVRs are still fairly helpful. And sometimes where we don't have a good read on what we're looking at, or we can't get good visualization, somebody with a lot of midline obesity will do CAT scans or MRIs to get a better idea, especially in the central system. Earlier we've talked about ankle brachial indices. Normal is 0.9 to 1.3. Severe is less than 0.5, but don't take an ankle brachial index. As Dr. Hartman alluded to earlier, if the vessels are calcified, it will often look like an arterial and ankle brachial index is in the normal range, and in fact they'll have severe peripheral arterial disease. Also, when reading an arterial duplex, somebody will say they have a normal ankle brachial index that's only based on one vessel. If they have a wound, don't stop there. They still need further workup because going back to the angiosome concept, there may be disease in other vascular beds that need to be addressed. For anybody who's ever had an ankle brachial index done or seen one, we put blood pressure cuff in the arm. We think the blood pressure in the arm should be essentially normal, or a ratio of 1. Compare that to the lower legs. And then we also do digital pressures. We have little blood pressure cuffs that we put on the toes that actually measure the pressures and predict the wound healing potential. And the numbers that are key that I was taught when I was a kid, and when you're looking at a report, and the diabetic is greater than 55. You want digital pressures greater than 55. Now we have adjuncts where we actually can look at the blood vessels within the foot, the plantar acceleration times, and whatnot, which can give us an even more accurate indication of the flow within the foot. But this is a very good and quick way of seeing whether or not the patient has a chance of healing a wound. Adjuncts to arterial duplex, obviously, like we talked about earlier, we'll use MRA, CTA, or conventional angiography, diagnostic angiography. And now we'll talk about the physics of Doppler ultrasonography. Not hardly. It's 3 o'clock in the afternoon. But duplex ultrasound is really important. And literally, in order to get through a vascular fellowship, all of us had to be trained ad nauseum in ultrasound, and it guides everything we do. It's accurate, reproducible, it's non-invasive, and it tells us, it guides what we do every single day. And so a brief reminder of your venous anatomy. There's a superficial venous system, the deep venous system, and this picture is a great ultrasonographic picture of the valves within your vein, what happens when you get the valvular release. So the top picture is a closed valve, and the bottom picture is when the valve opens. A DVT ultrasound, when you send somebody for a DVT ultrasound, if you've never seen it before, essentially you compress the vein. You take the vein, if the vein is compressible, completely compressible, you can see the one where it's totally flattened out. That suggests no evidence of DVT in that section right there. But when you try and compress the vein, as the picture in the bottom right, and the vein doesn't completely compress, that suggests there may be a DVT. Now, there are adjuncts you can do to that. You see the image in the top with all the bright colored pictures. That's the presence of a DVT. The bright color is the artery, and sitting right next to that is the femoral vein, and with no blood flow in the femoral vein, you can see there's a clot in that femoral vein. So ultrasound for beginners, it's great. We do ultrasounds also to rule out more proximal obstruction, as Liz alluded to earlier. We look for the compression of the iliac vein. I won't bore you with that, but we do actually measure the diameters of the vein to get a better sense of if they may have venous compression. It's not a perfect test, especially in somebody with a large BMI, but it at least can give us an idea as to why they might be having swelling and guide venogram studies. So, when should you refer these patients? You want to get them to us before they start their ulcers turn to something like this. This actually ended up in limb loss. This ulcer was so bad and the patient ended up dying. They can get such bad venous occlusion that they actually get gangrene of the legs. Same patient, same patient. Those are pretty extreme cases, but that was a truck driver who sat in his car and got massive DVTs and ignored them and became septic and died. So venous reflux, Dr. Gardner kind of explained that better than even I could earlier, so I'll move on from that. But the way we look for venous reflux is we do it with duplex ultrasonography. Again, we put them in tilted positions to determine how quickly the blood returns. A reflux time that kind of becomes stagnant or drops down for greater than half a second or 500 milliseconds is indicative of venous insufficiency. So that's what you're looking at when you're looking at our studies that we produce. Oftentimes we'll put the times on there, especially in the superficial venous system, the greater saphenous venous system. And I think when you're talking about referring a patient, it's important to have an idea of what you're looking at from the entire body. So, this goes back to physical exam. If you hear a bruit in the neck, send them to somebody. You don't need to get any other studies. But when we're talking about carotid disease, joint guidelines came out in 2011 created by the American Heart Association, the American College of Cardiology, in conjunction with the Society for Vascular Surgery. And I know we've been focusing so much on peripheral lower extremity arterial disease, but it's important when you're seeing all these patients to think about in the back of your mind other beds of vascular disease. Carotid disease, any patient with a history with greater than 2 risk factors, including high blood pressure, high cholesterol, tobacco, smoking, first-degree relative with atherosclerotic disease, presence of a Bruy on physical exam, or a family history of ischemic stroke. Those are indications to do a one-time screening for carotid artery disease. And then symptomatic carotid stenosis, obviously the patient presents with stroke-like symptoms. That obviously is an indication for some sort of workup. And it's amazing how often that gets missed. A good arterial duplex will prevent the patient from having a stroke down the road if we do find a critically significant carotid stenosis. And this can be numbness, paresthesias, weakness of the face, dysarthria, things like that. So I don't know why the picture didn't come up. So abdominal aortic aneurysm, who's at risk? This is another bed of vascular disease that you have to think about, especially in the southeastern region. It's more prevalent in those over the age of 60. Smokers, and males. It's much more prevalent in males than it is in females. And a family history is important. Probably the most famous person in history to die of an aortic aneurysm. His actually was repaired. It was wrapped in cellophane by a guy named, I think it was Mayo. And that fixed it for about 5 years until it ruptured and killed him. So this is one of those aneurysms I was alluding to earlier. It's not subtle, but in most patients it is subtle. In most patients it's found incidentally on CT scanning for other incidences. But it's something you should think about and look for. Medicare and the U.S. Preventative Services Task Force actually recommend a one-time ultrasound in men greater than 65 who've ever had a cigarette. So in those patients, you should definitely be screening for abdominal aortic aneurysm. And that screening is very easy with a one-time ultrasound. You just starve the patient for 12 hours, and you usually get a very good image of the aorta, and you can determine whether or not they have evidence of an aneurysm. Also, we look for patients with family history of abdominal aortic aneurysms to screen. This is an excellent picture of both a transverse and sagittal picture of an aortic aneurysm on ultrasound. Like I said, you can get a very good idea of the size of the aorta on ultrasound and a good trained sonographer. The sensitivity is 95 to 100%, and the specificity is upwards of 100%. So, I mean, that's pretty outstanding. Oftentimes when we see these patients, we will get a CAT scan if it's closer to size criteria where it's something we need to fix. So, thanks everybody for your attention. Appreciate it. We'll open it up to questions.
So it's been a long afternoon. Everybody still seems to be bright-eyed, though. This is great. Should we turn the lights up a little bit more, or a round of coffee for everybody? Is there any questions out there about the different conditions we were talking about? Good catch.
I mean, she had a May Thurner, but we think the rupture comes from just a spontaneous increase in pressure. If you increase your pressure in your vein for some, I don't remember what she was doing, and all the, this is such a rare thing to happen, but. No, it was just a true May Thurner iliac artery compression of the iliac vein, and then it increased pressure distally to the point where it just weakened the wall. I mean, the wall is weak there, just proximal to that compression, and it ruptures.
It's interesting. I've seen a couple aneurysms from that sort of thing, venous aneurysms. As a matter of fact, I repaired one with you when I was in fellow from that exact pathophysiology, and so it's pressure related, and increases in size, and probably was there forever and ruptured.
And one of the things when we see, take care of patients with that unilateral left leg swelling, and they have the pain, pressure, heaviness in their leg, and it's, you're thinking in your brain, this is probably May Thurner's, and you get your ultrasound, and ultrasound says May Thurner's, and you do your imaging, you see the compression at that iliac of the artery on the vein. And what I often do is look at the character of the vein as I'm looking with the IVUS, and we're looking for really bright echoes throughout that vein, so it basically becomes scarred. There's a lot of fibrosis in that vein, and maybe that was the etiology. I don't know. I've never seen that, and I don't think I would have done well on the boards if you gave me that question. So I might not be here. Yes.
Don't hit him like face.
No more from.
A lot of my nurses friends have like a spider veins and varicose veins, due to our work. And so when should we start being concerned about them? Like if you have them, you just automatically have to have some kind of treatments, or?
So, I mean, if they have spider veins and varicose veins, as far as treatment, it really becomes when they become symptomatic. And you can treat spider veins just from a cosmetic standpoint at any time. And that's just a personal preference if you want to get rid of them. Typically, it's a treatment that we inject them, takes about 20 minutes. I do both legs front and back, and we retreat in about 6 months. So it's a process, 6 weeks. It's a process, and basically we treat them, we damage them, your body will kick in, they'll get better, and then we retreat.
So if you don't have symptoms, is that okay with the varicose vein, as long as you just wear compression stockings?
Well, there are plenty of people that do fine just in compression. So yes, I mean, if they're asymptomatic, then you just wear compression. Otherwise, you're going to have to pay out of pocket to have them fixed. When they become symptomatic, that's when they can meet medical necessity. But I see plenty of people that have pretty significant veins, and they say, yeah, they don't bother me, so they just wear compression.
Oh, okay.
So again, that's it's either a medical or a cosmetic issue, and so sometimes that really determines if people are going to get them fixed and whether or not they're symptomatic.
Does the insurance cover if a varicose vein becomes symptomatic?
If they're symptomatic, yes.
If it is
So
symptomatic.
there's criteria that every insurance company has. They're all a little bit different, and you have to make sure it meets medical necessity before you can treat.
Thank you so much.
You're welcome.
Here, let me throw that at you.
Okay, time's up. Okay.